Okay. Oh, welcome to today's webinar. Thank you all for tuning in. And we continue to welcome more who may join us later. Otherwise, my name is Purity Monene Wawero, a pediatric diabetes nurse educator who's been well trained and have a passion for the type 1 diabetic management. I am working at an endocrinology clinic whereby in Kenyatta Hospital, pediatric department, in a endocrinology clinic, whereby every Tuesday morning we attend to these patients. Today's, our webinar is on exercise and school in the child living with diabetes type 1. We will be taken through by our two very able presenters who are, we have Philip Mumo Mutisia, who is a certified pediatric diabetes educator, who has also done Bachelor's of Science in Nursing and has also gone through a DECA program that was sponsored by the ESPAD. He has a great experience in dealing with this type 1 diabetes for the last 6 years, and he has a passion for the same. We'll also be joined later by Monica Saulu, who is Philip Mumo is working in a Machakos Level 5 hospital. Later on, we'll be joined by Monica Saulu, who is a pediatric diabetes educator, who is working at Aga Khan Hospital, Aga Khan University Hospital in Nairobi, whereby they happen to attend so many patients with so many children with diabetes type 1. And she has she's very passionate on this condition, and she does her work very, very well. So you are very welcome, and we'll start with Philip Mumo Mutisia, who is going to take us through the exercise. Welcome.
Thank you, Purity, for that warm welcome. I appreciate that. Today we are going to learn about managing exercise in type 1 diabetes. As we all know that exercise is an integral part in diabetes management, and children are not limited to that. So we are going to learn about exercise in type 1 diabetes. So to start with, we'll look at the introduction, types of exercise, benefits of exercise, barrier to exercise. We'll also look at a structured approach to exercise. Then we'll also look at the current basic guidelines we have currently. So in introduction, exercise is very beneficial and should be encouraged. Diabetes should not be a barrier to participating in exercise. Children and adolescents should do at least 60 minutes per day of moderate to vigorous intensity, primarily aerobic physical activity across the week. We look at the aerobics and anaerobics, later type of exercise. Then we also have a vigorous, intense aerobic activity and activities that strengthen muscles and bones should be incorporated at least 3 days a week. That is according to the ISPAD guidelines. However, it is recognized that many families do not adopt to these recommendations. So young people do not achieve the recommended time. This could be due to maybe perceived lack of time, maybe lack of motivation or resources to do these exercises. The other challenges we have been experiencing, and I believe most of the people working in different areas have experienced the same, is the challenge of maintaining stable blood glucose levels before, during, and after exercise. That has been a very big challenge to most of the people managing type 1 diabetes. The other thing that has been a challenge to exercise, and I've gotten so many patients and maybe caregivers telling me that fear of hypoglycemia, especially at night, has been a big challenge for their children were doing exercise. Especially they have experienced a lot of hypoglycemia episodes, especially at night. That has tend to make them not to do exercise. So it is our responsibility as healthcare workers dealing with diabetes to assist these families so that they can overcome these challenges. We know that in young children, physical activity is usually unplanned. So in regards to it, it is difficult to make planned adjustments, maybe to insulin or to carbohydrates. So caregivers need to be equipped to problem solve the challenges arise. In contrast, maybe older children and adolescents may be engaging in a more structured exercise, especially in schools. They usually undergo maybe such activities like school sports and curricular activities, which may involve competition. So at least for the older children and adolescents, at least they have a structured way of doing exercise, and we can be able to adjust their insulins and adjust their carbohydrate they are going to take before exercise, even during exercise and after exercise. Then exercise management for the young children with type 1 diabetes, it's a complex thing. And one approach does not fit it all. So we need to incorporate many approaches in managing their sugars during exercise. And many individuals with type 1 have gone on to accomplish extraordinary sporting achievements. So we need to encourage our type 1 diabetes children to not to continue doing exercise. And I was reading about a story of one of the greatest players playing for Real Madrid. His name is Jose Nacho Fernandez. This guy was diagnosed with type 1 diabetes at the age of 12. And at that time, he was an academy player for Real Madrid. He was hospitalized and diagnosed with type 1 diabetes. And the doctor at that time told him that his football days were over. However, he sought to seek a second opinion from an endocrinologist who told him that it's essential for him to continue playing as the physical exercise was important. And that guy has gone to play for Real Madrid for the longest time possible. I think now he's about 33 years old and still playing for Real Madrid. So what are some of the types of exercise and effects on blood glucose? One, we have aerobic exercise. This aerobic exercise is just a low intensity exercise. And examples, we have cycling, jogging. These will lower your blood glucose as your muscles use glucose to give you energy. And another example of exercise we have is anaerobic exercise. It's an high intensity exercise, and examples are resistance training, weightlifting, or sprinting. And these ones are likely to cause an increase of blood glucose as your body releases stored glucose from the liver. However, your blood glucose is likely to drop later after maybe continuous activity. So what are some of the benefits we have of exercise? One, it sharpens the mind and tones the body. Yeah, it reduces the blood glucose flow to deliver all the nutrients required to carry out the brain job. So it's very important to do the exercise because it sharpens the body and tones the body, it sharpens the mind and tones the body. Another benefit it helps control stress, improves mood, and overall well-being. It pumps up your endorphin. These are neurotransmitters in the brain, which they are feel-good neurotransmitters. Another benefit is it aids in weight management and weight loss. There are those patients, but specifically I think for type 2s, whereby they come and their main goal is to have a weight loss. So exercise is one can be used to aid in weight management. It also improves blood pressure and cholesterol levels. Another benefit will be it increases insulin sensitivity and lowers your blood glucose. We'll see how as we continue. So what are some of the barriers to exercise? I've picked 3 barriers because there are some of we have tend to experience, especially in our working areas. And one of the barriers is fear of hypoglycemia. As you know, the risk of going low is increased with doing exercise or especially at night after doing the exercise. But these fears, we are supposed to encourage our patients to continue doing exercise and at least come up with a structured plan on how to check sugars, to monitor sugars, to lower these fear of, to eliminate the fear of hypoglycemia. Also, we need to incorporate the issue of giving carbohydrate. We'll see how we'll do that as we continue. Then the messaging at diagnosis. Some of the messages given at diagnosis that they should not do exercise because it puts them in danger. We should not encourage that. We should allow patients, encourage them to do exercise at all time. So the first impression matters, as people say. So when you encounter a patient with type 1 diabetes, let's encourage them to do exercise. Then also the healthcare professional may lack confidence. Healthcare workers may lack confidence that these patients on a structured way of doing exercise, or rather may have low understanding in exercise management on how to support these children with diabetes. So these are structured approach to exercise. We have a structured series of questions for exercise consultations, and we start from inwards, outwards. We start with the patient's goal. We need to understand what is the patient's goal. Is it, like I said, is it for weight loss? If it's for weight loss, insulin reduction based strategy to manage blood glucose during exercise, to avoid exercise after, to avoid low blood sugars after exercise. Then is it because of exercise performance? There are those who do exercise for just performance. Is it for socialization and fitness? Is it for glycemic goals? Because there are those who want to control their sugars. So the first thing is to identify the patient's goal. Then number 2, we need to ask what is the exercise type, duration, and the density. This will allow anticipation of expected effect of blood glucose levels. As you know, continuous aerobic activity performance, when insulin levels are high, will result in decrease in blood glucose and require reduction in insulin and increase in carbohydrates. But short duration, high density aerobic or anaerobic activity may result in post-exercise hyperglycemia. as I said there when we are doing the types of exercise. And this will require insulin correction dose of about 50%. Then we encourage to do an aerobic cool down session, so that to counteract the post-exercise hyperglycemia. Then after that, we look at the timing of exercise related to last insulin, bolus, and basal. Then we'll advise on how to adjust bolus and basal insulin. Then we also need to ask ourselves, is this exercise planned or is it unplanned? If the exercise they are going to do is planned, it's easy for us to adjust the insulin doses. So it's easy for us to advise them to adjust their insulin doses before the exercise. If it's unplanned, then we are only left with one option, maybe to give an extra carbohydrate. Then last but not least, have there been any episode of hypoglycemia prior to exercise? And the recommendation here is we do not exercise if you end an episode of hypoglycemia within 24 hours. That required assistant individual to treat the event. If you end an episode of hypoglycemia that you are not able to treat yourself, you required assistance from different person. So we recommend that you do not exercise. Then what are some of the basic principles when we are doing exercise? One, it's monitoring blood glucose before, during, and after exercise. Then eating enough carbohydrates. We'll see the amount as we continue. Then adjusting insulin as necessary. Then the guidelines for starting exercise. When your sugars is below, when we advise the patient, when their sugars is below 4 millimoles per liter, first they need to treat hypoglycemia by eating 15 grams of fast-acting carbohydrates. I believe Dr. Joyce Bogo covered hypoglycemia treatment very well. Then you're supposed to retest after 15 minutes. If the glucose levels rise above 5 millimoles per liter, they are supposed to follow with the slow-acting carbohydrates. Then they are supposed to delay exercise for at least 45 minutes. Then when the sugars are between 4 to 7, they can have a top-up snack prior to exercise and continue to go ahead and do the exercise. But when the sugars are between 7 and 14, it's okay for the low-intensity exercise to be started. The exercise, they need additional carbohydrate for exercise that is lasting more than 30 minutes. They also need to monitor glucose closely during the exercise. When the sugars are more than 14, and they are able to measure ketones. One, if ketones is more than 1.5 for those who are using ketone meters, or those are using glucose sticks, if the ketones are more than 2 classes, you are not supposed to exercise. They should not exercise because they will be, maybe they might be having decay. Yeah? So it's first good to monitor the ketones. Then if the ketones are below 1.5 millimoles or below 2 classes, they should take a reduced correction dose, that is around 50%, and wait for 30 minutes for a response. If glucose decreases and feeling well, it's okay to exercise at a low intensity with caution for a duration of, they are supposed to at least exercise for less than 30 minutes with frequent glucose monitoring. So we are supposed to monitor glucose closely when the ketones are below. At least there are traces of ketones in maybe blood or urine. If the glucose does not decrease, then do not start exercise. So some of the guidelines for carbohydrates required for 30 minutes exercise. This side we have glucose levels, the weight of the person. So if we start with the highest, if the blood glucose levels are above 15 and the weight of that person is 10 to 30, 30 to 50, more than 50. If they are feeling unwell, kindly let's advise this patient not to exercise. But if the sugars are between 10 and 15, we don't need an extra carbohydrate. So we have 0 grams. But when the sugars are between 7 and 10 millimoles, and they weigh 10 to 30 kgs, we need at least 5 grams of carbohydrate, and they can go ahead and exercise. But when the sugars are 4 to 6.9, we need more carbohydrates. That is between 10 to 30 kgs, we need 10 grams. Between 30 to 50 grams, we need 20 grams. And more than 50 grams, we need 30 grams. When sugars are below 4 millimoles per liter, you need to treat hypoglycemia. I believe you all know how to do it because we have undergone these webinars and Dr. Joyce had tackled it very well. Then what are the guidelines of adjusting the bolus insulin? If the activity is within 2 hours of bolus insulin injection, before the activity, we need to reduce the pre-meal insulin. And some of the examples of the activities I've listed here, we have a light activity whereby slow walking, gardening, dancing. So if the activity is lasting between 15 to 30 minutes, we need a 10% reduction of bolus pre-meals before activity. And if reduction to pre-meal after activity, if the activity is lasting between 15 to 30 minutes, we don't need an adjustment. Then we continue with the moderate, whereby we have brisk walking, hiking, cycling. So those are some of the types of moderate activities. So if it's before the activity, we need to reduce the pre-meal insulin, that is the bolus, by at least 20%. Then after the activity, you increase by at least 10%. Then we go to vigorous, whereby we have running, playing football, aerobics, all that. If it's before activity, we need to reduce the pre-meal insulin by at least 30%. Then after the activity by 15%. Then guideline for adjusting basal insulin dose. If we anticipate that these kids are going to have a very active day, more than usual routine, then we need to reduce the morning basal insulin by 20%. If someone is on basal insulin twice daily, then after exercise, we need to reduce by 20% to avoid hypoglycemia at night. I believe most of our children now, we are moving them from mixed, that is premixed insulin, because it doesn't have a good control in our children, and we are adopting the basal bolus regimen, which is the best and has good control. So kindly, for those who have not switched to basal bolus, it's high time to do so, because let's leave a mixed to the adults. And that's my parting shot. Thank you very much for listening to me.
Okay, thank you very much, Philip, for that wonderful presentation on exercise in children with diabetes. This time I'm going to welcome our our presenter, the second presenter, Monica Saulu, who is going to take us through diabetes in school. Monica, you are very welcome. And then we will combine the questions and we continue forwarding our questions. And then we'll do them all together at the end of the presentation for both Monica and Philip. Thank you. You are very welcome, Monica. Monica, can you hear me? Monica, please, you can take over. Philip has finished the presentation on diabetes and exercise. Welcome. I can see Monica is preparing the slides. I think we can just continue waiting and then we continue even raising questions on the exercise. And as we wait for Monica to start and take us through the diabetic in school. Oh, Catherine, I can see you are on the line. Maybe you can help. Catherine, we can't hear you also.
Thank you, Purity, for the evening. Thank you, Philip, for your presentation. Can you hear me?
Yes.
Yes, let's give Monica a few minutes as she tries to sort her microphone. I think she has a small hitch.
Okay,
but
thank you.
she'll be joining us very soon. Kindly be patient as we learn together.
Okay, thank you. Thank you. Let us wait for Monica. And as we've had, we've just gone through the exercise and school and the school going children. And we always say that a child with diabetes should exercise like any other child when they go to school. But what we need to do is just we have to make sure that if this is a child in school, we make sure that the teacher has gotten to know that the child has to carry the high pocket in the sports field, and the sports teacher has to know where the high pocket is. We emphasize on that. So we teach both the parents and the teachers. And for the teachers who are able to come for education, or if we are able even to reach them at school, we can do it for the sake of the child with diabetes exercising like any other child. So I think this is very important to learn to reach our children. And then there's also this thing about discriminating. We should not discriminate our children in school because they are having diabetes. A child with diabetes should be treated like any other. So as our presenter continue waiting and preparing getting ready, it's very crucial to know that we emphasize that children should not be discriminated in any way, and we should report any discrimination or any stigma that is noticed within the school or within among the teachers to handle our children. Thank you. I don't know whether as we continue waiting for Monica, if there is any other panelist who has anything to comment about the session we've just gone through, the exercise and the school child. Okay. As you wait for Monica to, because I think there's a problem with her microphone, we can take some questions. You can post some questions, or so that we can continue, so that we may not have a big gap in between. As we wait for her to get ready, please. Any question on exercise and school going child? And this, we remember we are talking about school going children. That means the adolescents, youth, and even the young adults who are in all of them, because they can be diagnosed with diabetes at any point of the age. Hello? Yes. Okay, there's a question about, there's a Violet Mtias who has asked, please, I didn't get the insulin that's to be used in pins apart from mixed. And then for this one, I think Philip was talking about exercise and charms and school, and because we're having a series of education on mixed and on use of insulin, I think okay, the question is, please, I didn't get the insulin that's to be used in pins apart from mixed. Okay, this question
Purity.
is to Philip.
Yes, I think I can answer that. Yeah, sure. Thank you, Violet, for that question. As I said, we are moving from mixed, but I didn't give some of the examples we are using currently. Now we are having current guidelines and new regimens for type 1 diabetes children. Currently, we are using what we call a multiple daily injection, and multiple daily injection is a combination of basal bolus insulin. And for example, basal bolus insulin, currently the basal bolus insulin, we have a long-acting insulin. For example, a long-acting insulin, currently we have, it's for example, like Lantus. Lantus can be used. Then, with combination of either rapid or regular insulin. Regular insulin, for examples we have, and I believe most of the areas have regular insulin. The one we have is Actrapid, or soluble insulin, as it is known. So we combine either Lantus and Lantus and regular insulin. We also have intermediate acting insulin. Currently, I think that's what we have in most of the counties. That is NPH. NPH, we combine it with either rapid acting insulin or soluble insulin. Thank you very much. So we are moving from mixed completely. But I believe we'll be having trainings for the switching from mixed to basal bolus insulin. Thank you.
Thank you very much for that answer, because it's good to emphasize that in pediatric, we are moving completely from mixed, because they don't do well, because these children are growing and they need to continue feeding well, as well as they continue getting the insulin. And so when you talk about we avoid completely, we come to Atrapid as a fast acting, and Novolapid as a rapid acting, and then the Lantus which is a basal. So we go with pre-meals, and then we end up now with the basal. There's another question which has been asked by anonymous at the D, asking, kindly expound on the post-exercise hyperglycemia. Thank you. Kindly expound on the post-exercise hyperglycemia. Philip.
Yes, thank you very much, anonymous attendee, for that question. I said some of the activities that might lead to hyperglycemia. Example is weightlifting, sprints, like you just like 100 meters, you just want to sprint. Then competitive sports. These are anaerobic exercise, and this one will cause you to produce stress hormone. Stress hormones will be produced, and example of stress hormone is adrenaline. Adrenaline will raise your blood glucose levels by stimulating your liver to release glucose. Thank you.
Okay, thank you, Philip, for that question, that answer, which is well answered. There's another anonymous at the D asking, hello, or commenting, hello, thank you for preparing this very insightful presentation. I would like to be receiving the links to attend future webinar. How do I go about it? Thank you. I don't know. This one, I think if you've, for the one who has asked this question, Philip, I don't know whether you can answer first.
Okay, I think these webinars have been running for around 6 weeks, and I think we continue with the webinars, and links will be sharing. Kindly just share your email, and the link for attending these webinars will be shared to you. Thank you very much.
Yes, I think you can also go, because it's been on a website, KNH, University of Nairobi website, so you can follow and you'll be able to get it. So there's another question from Jalab Ashraf. Ashraf is asking, sorry, I may have missed the early part of the talk. Enlighten me how do you determine 5 grams of or 10 grams of carbohydrate? Which are the fast acting carbohydrate and which are the high glycemic index carbohydrate? Philip, you can hear me? The Jalab Ashraf is asking, sorry, I may have missed the early part of the talk. Enlighten me, how do you determine the 5 grams or 10 grams carbohydrate? Which are the fast acting carbs and which are the high glycemic index carbohydrate? Can you hear me? Philip, can you hear me? Anyone else can hear me and answer that question?
I think we've lost Philip. He may have dropped off the meeting.
Okay, so what I think, let me answer that question. So, sorry, Philip has lost the network, and this question is asking about, sorry, I may have missed a part of the enlightened. How do we determine 5 grams or 10 grams of carbohydrate? Or according to the 5 grams of carbohydrate, we talk about the 5 grams carbohydrate, 15, every 1 unit of insulin is equivalent to 15 grams. So when you do carbohydrate counting, and when we do carbohydrate counting, I'm sure we'll be taken through to know exactly what is 5 grams in all the items we are able to feed on. When we go through the nutrition and the carbohydrate counting, this one will be answered, because I'm sure this series of diabetes and children and management is going through. So I think this question can be answered. And even right now, I can call upon anyone who may answer this. I don't know whether, Catherine, you can answer something on this question.
Purity. Yes, Purity. Good evening. Thank you for that question from Jalab. He asked about, to be enlightened, how do you determine 5 grams or 10 grams of carbohydrates? So these ones are determined by the type of food that you want to eat, or the type of food that a patient wants to eat. For example, you will have different foods, especially the ones that have carbohydrates containing different carbohydrate contents. For example, like Purity has said, you see like a slice of bread has 15 grams of carbohydrates. The normal bread that we're having in our country, that is 400 grams, that one has 15 grams. So it will be determined by the food that you have. The nurse educator and the nutritionist, together with the doctor who is seeing the patient, will have given the patient which kind of carbohydrates or what amount of carbohydrates contain what grams, what types of foods contain what grams of carbohydrates. Again, for the patients who will have the prestige of having a weighing scale, then you are able to measure which kind of carbohydrates are going to be contained in that specific food. Then the second question, Jarab asked, which are the fast-acting carbohydrates? For examples of fast-acting carbohydrates, they include that you need to correct maybe the hypoglycemia. During exercise, we have an example is quick sugar, which is the table sugar that we are having in our households. We have honey, then we have soda, around 200 ml of soda. Then we have glucose. And then for sweets, we specifically ask for patco, because one patco has around 5 grams of carbohydrates. Then you ask your patients to measure, depending with the weight of the child. You will ask them to have, if the child needs to take 5 grams of carbohydrates, then you will ask them to have the teaspoon, because a teaspoon has 5 grams of carbohydrates. If it's someone who's supposed to take 15 grams of carbohydrates for the quick sugar, then you ask them to take a tablespoon, which contains 15 grams. I hope I have answered you well. Thank you.
Okay, thank you very much, Catherine. That's a very wonderful answer. That's very good. That's a very good input. And as we continue, the questions which are coming now, we have a question from an anonymous entity asking about the webinar. Our award CPDs have not been attending, and I haven't had points from the same. There's also another one still, Kelvin Langat, who is also saying.
Excuse me, Purity.
Yes.
Leave the CPD questions. I'll be able to respond to them. Hello.
Thank you, Nelson. I've had that. Thank you very much, because there are many. There are about 4, 3 about the. So that's all I can say about the question, about the exercise, about the presentation, and so far I don't know whether still we are waiting for Monica to come in, or we continue waiting for more questions. If there's any other question that is concerning the school. Any other more question?
I think we can proceed with the Monica.
Monica, please, if you are ready, we can continue with you now. Are you there? You are welcome, and we are sorry for what has happened, the network and whatever, the microphone. If you are ready, please, you are very welcome, and we are ready to listen to you, from you.
Monica, kindly confirm if you can hear us, or just speak so that we can see whether we can hear you.
Hi, Monica. Is it possible for you to write us on the Q&A, on the chat box, for us to be able to answer you, because we can't hear you? Thank you.
That we have the, making sure that they have a well-labeled, the teachers where they are going to school, that the teacher is aware about all what is going on about this child, the emergency contact the parents, the emergency place in case the child falls sick, and maybe the next of kin in case a child falls sick while at school. And then now we also take measures. There are key points where we make sure once these child go to school, there are leaflets or letters that are printed to the teacher about how the child is going to be taken care of. Maybe like now and during the meals time, the child should not be meant to queue for long. Whatever, the child should be allowed to carry snacks. There should be no exchange for snacks. There's a lot of a written document of proper guidelines on how this child is going to be treated in school. And I know because we are going to go into this in details later on, I thank you very much for listening, for tuning in this webinar, and despite whatever those inches which are coming. So this time we are coming to the end of our webinar. I think we thank you all for listening and looking forward maybe to continue this one into totality and to make sure that we've gotten this one, diabetes and school management. And we can also take in consideration that even in school, the children are allowed to carry the insulin, the hypo kits, those very important things which can make a child fall sick while school and be taken to the hospital. So we have to work in coordination with the parents, the health worker, the doctors, the nurses, and also now the teachers plus the parents. And then we really insist and emphasize that children should not be discriminated. They should be allowed, and a child with diabetes shouldn't just be treated like any other child, but they should be given avenues in case of need. Testing, giving themselves insulin, how to take care of their snack, and even how to be given permission to go for short call, especially when the blood sugars are high. All these things are included. So thank you very much for tuning in, and I think we come to the end of it.
Purity, there is a question for Philip. I have an. Sorry for that. This is from Milka Bwana, and she's asking, like now, how do all the grams quantities in available hypoglycemic excess? Do they know about the insulin dose adjustment for insulin during exercise?
We are getting an echo from your end. Kindly just mute one of the devices if you have two devices on your end.
I still have an echo.
Now it's okay, thank you.
Okay, this was from Milka Bwana, and Milka Bwana asked a question, and this one is directly to Philip. Milka says, like now, how do all teachers know the gram quantities in available hypoglycemia quick fixes? Do they know about insulin dose adjustment for insulin during exercise? Philip, if you are available, that is your question.
Yes, thank you, Catherine and Milka, for that good question about teachers. What I can comment on that is that we're having a structured way of doing school health program for diabetes. So in that school health program, we usually cover hypoglycemia, exercise management in school. All that is covered. So it's high time we do the structured way of going to schools and educating these teachers. So we have a structured way of that. I think Monica will cover that in diabetes in school. Thank you very much.
Is there any other question, Catherine, you can see?
Purity, we have an anonymous late question, and she's asking, sorry for asking late, what is included in the hypo kit? Over to you, Philip.
Thank you very much for that question, anonymous attendee. What we have in an hypo kit 1, we should have a glucometer for checking blood glucose levels. 2, we should have a quick acting glucose, sugar or glucose or honey or whatever is available, like soda, specifically Fanta. If it's Fanta is available, we can also, like in our department, mostly we use glucose and sugar. Those are fast acting glucose. Catherine, if I've left anything in the hypo kit, you can go ahead and take it.
We can add Patco, which is available in most shops. And I think honey. I'm not sure if you had mentioned about that, but I think you have mentioned most of the things. Thank you, Philip. Back to you, Phil, the Purity. Thank you.
Okay, thank you very much, Catherine, for that help, that coordination. Thank you very much, Philip. Thank you very much, everyone who's been, Nelson, all of you who have participated here. And thank you for all of you, our attendants, our participants who've been, and also thank you for the questions which have been asked and even the ones who have been answered. And now we come to the end of this webinar. We are hoping to continue this series of diabetic management in type 1 diabetes. And thank you very much for listening. We come to the end of it all. God bless.